name is Brad Bengtson. I'd like to welcome you to our breast augmentation virtual webinar. We're excited to share with you everything that is important to know about breast augmentation, selection of implants, and just all the nuances that are really important. When considering breast augmentation, there are a number of really important factors that need to be considered. I really look at the state-of-the-art breast augmentation as including the following factors. The first is very good informed consent. So you have to be well informed about the procedure, the details of the procedure, the potential risks and complications, anticipated follow-up, recovery issues, and how to deal with just the weekend that you're in store for directly after surgery. The next is when you come into our practice, the first thing after meeting our team is that you will experience 3D imaging and simulation. So we use Canfield Vectra, and it is the single best way to actually navigate implant selection. And you can actually see the potential range of outcomes before surgery. So it's really important and significant. When we look at implant selection, there's a specific range that fits inside the breast and body. We call it tissue-based planning. The important factor of that planning is mainly the width of the breast. The key thing for me as a plastic surgeon, I want to match the width of your breast to the width of the implant. When we do that, then we can adjust the projection or profile of the implant to fill the space, and that will give you the best kind of natural proportional outcome possible. About 30% of the breast surgery I do is revisional from other plastic surgeons. Usually, that's the base width of the breast has been compromised, usually with too big of an implant. The soft tissue skin can't hold up the weight of the implant, so the lower skin bottoms out or stretches, gets what we call lower pole stretch. And so it's vitally important that the tissues are matched to the implant characteristics, particularly the width of the breast. So the planning is really critical with this operation. Second thing is the actual performance of the surgery is also vitally important. So done somewhere between 8,000 and 9,000 breast augmentations in the last 30 years, and we do around 300 or so breast augmentations a year in that range. And you develop a very good, successful, efficient routine. The key things to breast augmentation are to go through a small 1-inch fold or crease incision at the base of the breast. All other incisions create more complications. There's really no reason to go any other route. And I always tease patients, you really don't see that incision unless you grab your breast and lift it up. So it's just really blends into the crease and fold over time. But it allows us access, so we've modified some lights and instruments to actually create the pocket without one drop of blood. So the first critical thing is to make the surgical pocket to perfectly fit the width of the implant with no bleeding. When we accomplish that, there's much less swelling, bruising, pain, recovery. And the next important aspect of breast augmentation is a fast track recovery. So at the time of surgery, we block your breast with a long-acting numbing medicine. And so we basically infiltrate that into or inject that into the skin, soft tissue, some of the nerves around the breast, including the muscle. So we actually paralyze the muscle a little bit because there's that pressure feeling afterwards that you feel that we'll get into in just a minute. So the breast is very numb. So post-operatively, there's very minimal incisional pain. It's really more of a pressure feeling of the chest and the muscle kind of contracting over the implant. most patients can recover within 24 to 48 hours without narcotics. So there's some patients that do still require narcotics, but the vast majority of patients can recover very well, get back to normal activity super quickly. And so that really is the state of the art where we are today. One more important intraoperative aspect of breast surgery is the reduction of capsular contracture. So capsular contracture, let me grab my trusty implant here. When an implant is placed inside the body walls it off with a Ziploc bag of scar tissue. So it looks exactly like a Ziploc. It's like 1/10 of a millimeter thick, very strong. So it totally lines the body, totally lines the implant. It's not rejecting the implant. It is just saying, hey, this is not me. And so it kind of walls it off from itself. It used to be about 15-20% of the time that scar tissue could tighten around the implant, and it basically draws the implant up on the body. It can get very firm and create a lot of asymmetry and in really severe cases, pain. So about 15 years ago, 20 years ago, we started really researching capsular contracture. And what we found, it's due to one of two things. One, either blood or fluid in the pocket around the implant. So we do the surgery again without any bleeding, so it should reduce that chance of that being a factor. The other is a low-grade bacteria. So we do about 14 things to prevent capsular contracture. It costs our practice about $300 or $400. It's super important because before we've lowered the capsular contracture rate now down to less than 0.5%. So we have to do these things though and jump through these steps to reduce that extra scar tissue. Those really include triply prepping the skin. We put nipple shields on because we can culture bacteria out of 85% of women's breasts. We irrigate the pocket. It's completely bloodless, so there's no blood that can cause this problem or extra scar tissue. We irrigate the pocket with antibiotic solution and some dilute betadine to sterilize the pocket. And then probably most importantly, we put the implant in with a sterile funnel or sleeve. We take the implant right out of the box, put it into the sterile funnel. I think we also have that on our website, where we basically propel or push the implant through a small little incision without touching the skin. So all those things are really important because to treat capsular contracture is an option. We have some pretty good ways to treat it, but the best way to treat it is to prevent it. So the treatment of capsular contraction is super important. Post-operatively, one of my mentors, his name was John Tevitz, he just passed recently, and he taught me rhinoplasty and breast augmentation. And right into my career, he was my main cheerleader, my main mentor, and really taught me breast augmentation. And everything I do is kind of his kind of ideas, or my minimal modifications of those concepts and ideas. And I think the one of the most important things that he taught is you can have very minimal complications and you can get patients to recover very quickly. So the vast majority of our patients will recover within 24 to 48 hours. And most surgeons and most patients don't believe that. And so, occasionally we'll get particularly younger patients that have a little bit more of an emotional component, to their pain. You probably know who you are. Those patients are going to take a little bit longer to recover, but particularly postpartum patients who've had babies, they've had the reset on their pain threshold a little bit, but their breast has been stretched a little bit. Most of those patients will recover really fast, like 24 to 48 hours. And so it's really due to starting the fast track recovery in surgery. So it really involves the bloodless approach. So you're not traumatizing the ribs. and creating bleeding and which creates bruising and more pain and more swelling. So it's basically not one drop of blood. It's blocking the breast, so you get a great numbing of the breast. So it's really more of a pressure feeling. I've not felt this personally, but every patient, almost to the person, says it's kind of like my milk came in. I'm breastfeeding, my milk came in, that kind of general pressure. That's what you should expect. We have patients start moving their arms above their head right in recovery. So the fast track really involves active motion. So we really want you moving your arms above your head, kind of stretching your chest and really moving. You can lift immediately, babies, jugs of milk, those sorts of things immediately. We want you to really just have the mindset, okay, if I feel good enough, I could go out to dinner tonight. And so the vast majority of patients can do that and get to that point without narcotics, and it is real. And I have patients all the time come in and say, my friend had a breast aug. She was in bed for 2 weeks. She took 6 weeks to recover. She had all this bruising, swelling, glistening of her breasts, all that. I can totally relate to that. Early in my career, we used to do transaxillary augmentations with saline implants through the armpit, and there's no, control of the bleeding. So patients are very sore, a lot of swelling, a lot of pain. So I certainly understand that. The vast, vast majority of patients will easily recover within 24 to 48 hours with that gentle sort of pressure, sometimes more, pressure on the chest. And you can get back to work, long weekend. Some of the other recovery things we do, as far as within a week, you can do non-impact things. So elliptical, stationary bike, walking for exercise, those things. You could do lower body workouts, those things. About a month before you can get back to complete full impact chest exercises, those sorts of things. But that's kind of the routine, normal return to activity that our patients can achieve. So one of the absolute critical aspects of breast augmentation is implant selection. And I would argue it probably is the most important aspect of things, because ultimately at the end of the day, if you experience something that is different than what you're thinking, then the procedure can be a technical success, but it can be a failure as far as not meeting the patient outcome. So the first thing I think is really important. When you come to the Bengtson Center, we don't project onto you what you should have. Patients ask me all the time, well, what would you recommend? And my answer is, what are your concerns, right? And what do you want? So I'm trying to figure out for the last 30 years what kind of implant size selection works in each patient. And hopefully that will be in the range that the patient is looking at. But basically what we do is we'll actually measure the width of your breast, kind of the inside to the outside of your breast. And we want to pick an implant that's within about 1 centimeter of that width. If you go and exceed that, then you can kind of get a breast on top of a wide implant, and you kind of get a double bubble or just an implant breast mismatch. And it can create too wide of a breast. The implants can touch in the middle. I've had to, correct thousands and thousands of different patients that have come in where the base width measurement has been disregarded, and it's really, really difficult sometimes to fix. So the critical aspect of things is determine that range. I tell patients it's like the Price is Right game. Has the fridge at $695 and that red bar is going across, and you want to bang the button, when you're in that range. So it's about 150 cc's, 200 cc range that will fit. I'll let patients select whatever implant they want in that range because it's going to fit in your body. But if you're out here or down here, then I'm not your plastic surgeon, because I'm not going to put an implant in that I know is going to be too big or too small and not create an optimal outcome. When you match the implant width to the breast width, it automatically creates a beautiful breast shape. And again, there are multiple different implants that will fit within that range. The next big misconception, myth that patients have is, if I just go up one implant, or people come in all the time, particularly accountants that come in and they're like, you told me you're going to do 295 cc's and you put 310 in, right? So it's 1 tablespoon, right? So again, you take a couple cups of water and put a tablespoon in it. You don't see that. It's like 1 millimeter difference in projection. There's not a volume increase. You have to jump 3-4 implant sizes before you start to see visible changes and asymmetries in the breast. In fact, probably 60-70% of patients, we put different size implants in from side to side, because breasts are sisters, not twins. They're always different. One is always different one than the other. So we need to find that range. And then, to me, it's a really simple thing. It's not overly complex, or, you don't want to spend too much time thinking about it. It's either I want to be as full as possible, but still natural, or I'm decided I'm going to be a triathlete and I don't want my breast to interfere with my lifestyle. So, I definitely want an augmentation, but let's go more on the lower side. I want to make sure it's worth it, but I don't want to really be super obvious, those sorts of things. So kind of our genre and our kind of mantra is, the best plastic surgery is in patients you can't tell have had it. And so we want to pick an implant that fits the body, fits the breast, decreases complications and revisions. And again, 30% of the breast surgery I do is revision, and revision from prior surgery. So you just don't want to be on that pathway. It's just not a fun pathway to be on. I always tell patients, I'm happy to look at your breasts whenever you want, ultrasound your implants, but I never want to see your implants again, right? So, the potential we have today is for a lifetime outcome. These implants should last 20 plus years. And we don't have the data fully to support that yet, but we do for 10 years. And just the way these implants are made, I think that they're going to create some very significant longevity. So I think those are important things, and implant selection is the absolute key. The next important follow-up aspect is high-resolution ultrasound. So I just presented in Vancouver at our national aesthetic meeting. We have, as far as I know, the largest global experience evaluating breast implants with high-resolution ultrasound. I've ultrasounded about 20,000 breasts, again, in the last 25 years or so. And we have over 99% accuracy looking at implants inside the body. So what we do is we scan breast implants, particularly about every 3 years or so. We'll have patients come back in and just follow up with our own patients, but also we'll scan new implant patients back to the practice looking for breast revision. Super important to know if the implant's intact or not when you go into surgery, because you need to prepare for it. So with the current implants, I'm going to show you in just a second, they're really exceptional. Let's just look at one. So the new implants, hope you can see that here. We use an Allergan Natrel soft touch or highly cohesive silicone gummy bear implant. It's a 6th generation implant. Implants have been used since the 1960s or so. The important aspects of the new current implants are the older implants were underfilled, and they created kind of a collapse of the shell that allowed the shell to rub on itself, and eventually, like steel can cut steel, silicone can cut silicone. So there's about a 1 to 2% deflation rate over time. The new implants are overfilled, so there's really no way that the implant can kind of impact on itself to actually cause a fold flaw or shell failure. The shells are incredibly strong, so They can handle about 6 million mammogram pressures. Also, I ran over some with my Ford F-150 a couple months ago. We posted that on Instagram a while ago, so you can check that video out. But the implant shells are incredibly strong. The next important factor we'll show you during the consult. You can actually cut the whole implant in half and all of the gel stays inside the shell. So the safety profile is much, much better. And I would say about 10-15% of first-time augmentation patients, particularly weight loss patients or patients looking for a larger implant or poor soft tissue, will use an internal bra of a material called Galaflex. And Galaflex is a natural protein, and it's a really cool kind of futuristic sort of product. It actually turns into your own body's collagen. And in patients for breast revision, it's really vital and useful for patients that need some sort of support or like an internal bra. So with Galaflex, this is just a 4x4. We're going to show you what the Galaflex looks like as well. But if you can just imagine, we put the Galaflex along the lower part of the breast. So it's the lower pole of the breast to kind of reinforce the soft tissue as an internal bra or sling. And so in patients that, again, have stretch deformities or malpositions after prior breast augmentation, or come in a lot of weight loss patients, very kind of poor soft tissue, very stretchy skin, we'll consider using Galaflex at the immediate time of the revision. So those are some of the main factors that you need to think about. Getting proper informed consent, getting a good simulation where you can actually get involved with the selection of your implants, be able to visualize what that looks like, both with a breast lift as well as different implant sizes and position. Having very meticulous prospective hemostasis, that means no bleeding essentially during the creation of the pocket, perfectly fitting the implant, particularly the width of the implant, and then supporting the patient breast implants that need that with additional internal support, and then following up of the implants over time. We follow implants for life. With the new implants, we've not had a rupture. We've been using these for about 10 years now, but we can follow your implants long term. So that to me is where we are with the state-of-the-art breast augmentation today. Okay, so how do you choose a plastic surgeon, and particularly one that's going to do a breast augmentation, or really any procedure? So there are a number of really critical factors to look at when you're choosing your plastic surgeon. I think most people inherently kind of go through these steps, but there are a couple that are really critical, and it's what I use to choose a surgeon to operate on me or my family. So those really include board certification. So it's really important for any plastic surgeon or any physician in their area of specialty to be board certified in their specific area. Unfortunately, there are a lot of physicians, there are a lot of even non-surgeons doing cosmetic surgery. So it's really important for you to kind of research background, and board certification is a really critical aspect of that. The second, I think, is word of mouth. I think that to really ask around and determine who in town or in your region or in the area, or best you can determine on the internet, even out of state, does a really comprehensive, great approach for the procedure that you're looking for. So at the Bengtson Center, it's really interesting. We look at all of our patients, and at least 30% are beyond 200 miles of Grand Rapids. I've operated on patients from every state, every area of Canada, every region of Canada. It's a province, I think it's called. And then also Western Europe. So we see patients from everywhere. And we get a lot of inquiries, from the website and from word of mouth. One of our nurses was actually just in Denver, Colorado, and having dinner, sitting up at a bar before she's going to sit down and eat. And this lady just strikes up a conversation and is like, what do you do? She's like, I'm a nurse, I'm a surgical nurse. And she said, oh, really? Where do you work? And she said, in Grand Rapids, Michigan. She goes, I work for a plastic surgeon in Grand Rapids. She goes, who is it? And she said, Dr. Bengtson. She goes, oh my gosh, she just did my breast augmentation revision like 2 weeks ago. So crazy. I mean, so we, our scope is really broad. I think it's really important that you research and look also at the experience of surgeons. So, it's, I specialize, really hesitate to use that word, but I specialize. I really do certain things. I do the full gamut of cosmetic or aesthetic surgery, but there are a lot of things in plastic surgery that I don't do. And even if I go on mission trips and those sorts of things, if I'm not proficient, if I don't do those procedures a lot, like cleft lip and palate, burn surgery, I don't do those surgeries. I don't offer those surgeries even to patients in third world countries. There are surgeons that do that very well, and I'm certainly there to support and do things that I do really well. So I think it's really important to do your research, particularly what the experience specifically is of the surgeon. And then we talked a little bit earlier about, here are all the critical, important things. This is where the state of the art of breast augmentation is today. It's using the best implants available with the highest cohesivity that are the safest type of implant available. It's using simulation. It's using surgical techniques that are very precise, bloodless, follow up with ultrasound. All these things, super important, because this is not just a transaction. This is actually a lifetime, potentially a lifetime outcome. So you really want to really look at it as an investment into yourself and really do your research. Well, thanks everyone for tuning in to us today on our segment on breast augmentation. Make sure you stick around. We're going to have a very active question and answer period to get any other questions that you have answered. Really encourage you to either do a virtual consult for the out-of-towners or to come in for a consult. Really does take a physical examination for me to really give you that really accurate range and kind of walk you through expectations on getting the best breast augmentation result you can get. All right. Hello, everyone. Thanks for joining and sitting in. I also listened to the last 30 minutes and the production. And my first question is, did anyone count how many times I said really, the word really? I mean, I didn't really actually know how many times I said that. So I apologize for that right up front. So we're getting a lot of very good questions. First of all, I wanted to thank Pam. So Pam texted us in and said, thank you for the webinar. You did my surgery, breast augmentation, back in 2009. Still very happy. Everything looks perky and lovely, she said. So blessings to us, and so blessings to you, Pam. It's great to hear. So it is possible today to get very good long-term outcomes with current techniques and technologies. So the first question we had is, how long do breast implants last. And if you're able to go back to the webinar, I think we're going to post it online a little bit later on YouTube or on our website. At about 18, 19 minutes in, we kind of talk about the longevity. So the way the new implants are made, they're basically, I have one here. See if we can hold that up. So they're basically overfilled. Let's see if I can get my dark background. They're overfilled, so there's really no collapse of the shell. In the past, implants were underfilled and they could rub on themselves, and that's why the implants failed long term. Current implants that we use with the soft touch and highly cohesive, they're overfilled, so they can't really impact on each other. And so it's going to last a very, very long time. We've been using these for almost 10 years now, and I have not had a failure yet. I think they're going to last in the range of 30 years. We won't know until we get there, but I'm really very excited about the longevity of the new devices. Also, like we mentioned, they're very strong. They can withstand about 6 million mammogram pressures. My 16-year-old son, Will, thinks he's a movie producer now because he did a videotape of me running over my breast implants with my Ford F-150. So you can check that out as well. But they're very, very strong. And then you can cut the whole implant in half and all the gel stays inside the shell. So it's kind of like a gummy bear in nature. So the characteristics are much better. One potential patient, attendee asked about, I have a child in a crib. How long am I able to lift? When can I lift her in and out? The answer is the same day. So far be it for me to stand between a mom and her baby. So I actually have 2 new grandbabies in the last month. So super exciting, obviously, and we don't want to do anything that's going to inhibit that sort of activity. So the answer is the same day. So you can resume normal activity. Lifting is not a problem. So lifting in and out of cribs, even using your legs and lifting from the ground, kind of jugs of milk sort of weight. Within a week, you can get back to non-impact things. And really the restrictions mainly we have are really high impact activity and chest, like major chest exercises like push-ups and bench pressing for about 1 month. So next question, also a really good question, is what are the ages that you can do a breast augmentation on? So I've done breast reconstruction really in patients that have had an absent breast. So really just like no breast and then like a large breast on the other side. So it's not really an augmentation. It's more of a reconstruction in patients under 18. But for cosmetic reasons, usually patients are over 18. And I've done breast augs on patients into their lower 70s. So all those patients, the first thing they say is, why didn't I do this, 30, 40 years ago? So, so it really is more your physiological age, not your chronological age. So you can be a 90-year-old, 60-year-old or 60-year-old, 90-year-old. So it's really more about general health and those sorts of things that are really super important. Let's see. So I'm getting augmentation at age 40, and in theory, it lasts 70 years. So what are the surgical concerns at that age? So super good question. We get this asked all the time. Basically, once you have an implant in place in a pocket, you can theoretically do an implant exchange or removal under local. So basically, there's just skin and a capsule, and as long as you numb it up, you can actually, remove an implant or exchange an implant with very minimal sedation or under local. I see a lot of elderly patients that come into the practice, that elderly, old is always 10 years older than you are. So take that for granted. But, a lot of patients that are older that have had their implants for 40 plus years, we ultrasound them to make sure that they're intact. And there's really no reason to remove the implant. I always tease them and say, in all the nursing homes and everything around West Michigan, there's a Bengtson wing that have the ladies with the best looking breasts, in that corridor there. So there's really no time frame or anything to remove the implants or exchange the implants. One question was about breast incisions and scars, and we did talk and mention a little bit about that. This was mainly on first-time augmentation without a lift, but it's very easy for you to kind of self-diagnose whether I need a lift or not. There's a common rumor out there between patients and some plastic surgeons that I don't need a lift, I just need a big implant, and that'll take care of it. Or I just need just an around the nipple lift and a big implant. So hundreds and maybe close to upper hundreds of patients that we've had to revise to do a full mastopexy or breast lift and smaller implants. It's just very common. It's one of the most common reasons for revision. So when you're standing in a mirror, if you feel underneath your breast, or you can draw a little mark out from the inframammary fold. So the fold is where your breast attaches to your body. When you're sitting or standing, if your nipple is below that fold, if that is dropped down below the fold, then you need a breast lift. And there's really no way around it. I can't make your breast look good and have a good shape if we don't do a lift and you need a lift. So if it's only about an inch, then we can just do an around the nipple lift. So it's just an incision around the nipple. Usually it's just a fine hairline scar. If it's between 1 and 2 inches, then usually we add a little short vertical component to it. If it's more than 2 inches, then usually we're doing more of a full mastopexy. But those incisions are, the vast majority are hidden underneath the breast, and again, you're getting a really nice shape. That shape is the most important aspect versus the incisions, and we learned that from breast reconstruction. So let's see. Rumor that retirement is in your somewhat near future. Will you be practicing for at least a few years more? Probably some of my colleagues around West Michigan would like that to be true, but it's not. So one of my best friends is my pastor, Rod Van Solkema. He always tells me, if you want to hear God laugh, make plans. So everything is God willing. But I'm planning, God willing, to be practicing for at least 5 more years. We have a new associate starting here at the Bengtson Center that we're super, super excited about. Nargis is going to be here in about 6 weeks, and we're going to have all types of open houses. Our All That Glows event, I think September 19th this year. She's going to be kind of the woman of the night here for that. Just an amazing person, very talented. She's just finishing a breast fellowship in Houston. So I'm going to spend, the next 5 years kind of transferring all of my surgical knowledge and experience to her. So I plan on being around operating for a long time. So I'll let you know though when that point in time happens. So next question, range of cost for implants. So it's a really good question. They kind of keep me out of the money part. The best thing to do obviously is to come in for a consult, and then we can kind of give you a very specific quote. So it depends on a lot of factors. I mainly recommend the implant. The only implant that I recommend is the soft touch or highly cohesive implant. It's a more expensive implant, but it's worth it. Again, this is not an event or a transaction. It's hopefully a lifetime, device, or a long-term device anyway. And so how it feels, how it looks, the wrinkling, rippling, all those different things are really, really important. So our implant that we use is more expensive. We do, again, multiple things at the time of surgery to decrease complications, like capsular contracture that we looked at. And that adds probably $500 or more to the procedure. And just, I think that you're also looking at the quality, expertise, and those sorts of outcomes of the surgery. So our goal is to be one and done. And so, there's going to be a wide range of costs, but, I think that you're going to have probably less than a couple $1,000, swing, one way or another for breast surgery in Grand Rapids, West Michigan. The other thing, just to put a plug in, we have amazing patient financing right now with Patient Fi. And so it allows patients to pay for procedures over time. And actually, if they're approved, set up for their procedure, and then just have a monthly fee that they pay. So even higher net worth individuals are really taking care of that, or taking advantage of that, because it's just a really great option with very low or 0% financing for up to a year. So great option with that. So there's a question about implant exchange when you have a lot of scar tissue. So scar tissue can either be on the skin or it can be inside around the implant, which is capsular contracture that we just spoke about. So the answer is yes. I mean, we can deal with the scars on the skin. So we're always trying to get the skin envelope to match the breast and the implant volume like a hand in a glove. So we're usually, if you've had prior breast surgery, we're kind of reducing the skin envelope to match whatever the new implant and breast size is. Usually involves removing prior scars that you've had and creating brand new scars. If it's scar tissue within the implant capsule, so the extra scar tissue around the implant is called capsular contracture. It's used to be very common, much less common now. We have an amazing way to fix that. And so I've published in our plastic surgery journals lots of articles about using kind of sheets of collagen to kind of trick the body into not forming scar tissue back again around the implant. So we do have a great way to treat and fix capsular contracture. And so usually when patients come in for revision, they either have too much scar with capsular contraction or too little scar where their tissues are stretched and or you have displacement out, those sorts of things. So we have some great ways to treat both of those situations. So let's see. So the next question was about any future webinars on tummies and face. And we actually do have a upcoming website webinar on tummy tuck. I think it's July 23rd. So I believe Dr. Alfonso is going to be doing that. This fall, myself, Dr. Nargis, and Dr. Alfonso are all going to be doing some seminars. One we're super excited about is to bring a local celebrity in that has agreed to, who I did a face neck lift on, who has agreed to come in and kind of share her journey. And so I've known her for about 15 years. So it's really cool to look back at her journey with non-surgicals in the face, facial tightening and that, and then eventually a facelift and neck lift, and then her recovery. So she's going to come in and kind of share her experience and journey as well. So yeah, lots of exciting things to come. And if you have any other ideas on what you like to hear about non-surgicals in the face, we have 3 new technologies coming in the next 2 or 3 weeks that are super exciting. One is more facial tightening. We have a laser-based acne treatment program coming. We're always looking at new laser technologies. So we have a lot of really, really cool new technologies coming even this summer. So question about nipple sensation. So basically, with nipple sensation, there is a nerve on the outer aspect of the chest. So it's kind of where the breast attaches to the body toward the armpit area, called the fourth intercostal nerve. And that nerve, we're always careful to protect and not cut or damage, but the implant can push on the nerve just going into the pocket. And nerves don't like any sort of tension or pressure. So you can end up with some short-term numbness in the lower patch underneath the breast, or spotty numbness in the nipple. Most of that sensation in the vast majority of patients will return within about 6 months. I have seen sensation return up to 3 years, but loss of sensation, like globally in the breast, is almost zero. We do have some patients with some spotty numbness, long term, but you should be able to regain all the sensation in the breast long term. So, question from Jessica: do all surgeons in our practice use the same implant devices? Answer is yes. We really feel, both Dr. Alfonso and I'm sure Dr. Nargis, when she comes, is going to feel the same. We want to use the best implant for the patient that's going to get the best outcome, the most natural look and feel for the longest time possible with the fewest complications. And so personally, I don't believe there's any differences between saline breast implants safety-wise, particularly now that we use ultrasound to follow implants over time. I can tell you within 15 seconds if your implant's intact or not. And so, saline, more wrinkling and rippling, more firmness, and it's just, in a lot of patients that are particularly very thin, it's just not an ideal outcome. So to me, there's really no reason to use any other implant than the highest cohesivity. So it's the thickest gel on the inside. Again, you can cut these implants in half and the gel stays in the shell. They're strong. Obviously, they can sustain the weight of my truck. And so to me, there's really no reason to kind of go with a less expensive implant. There are other manufacturers, and there's a new implant coming to market probably by the end of this year that we're going to evaluate. But to me, these devices that we use are really the best options out there. So, so just a reminder that everyone attending will be receiving a text message, and you can reply with the code RENEW, RENEW, for a complimentary consultation. So everybody that has counted the number of times that I've said "really" in the last hour, regardless of that or not, we're going to waive the consultation fee. And we've also made some additional consult time. I know, pretty hard to get into, and I apologize for that. But we've made some additional time available, as well as some Saturday hours coming up to accommodate any consults and that for all you all that have listened, and for the future. So I think that's pretty much it. If you have any other questions, don't hesitate to reach out to Haley or I, Haley or Dr. B at bcaps.com, and we can answer any other questions that you have. Really encourage people that are local to come in for a consult. There's really no, it's just a huge benefit to actually go and experience the whole consultation process here. Get imaging. We can simulate you. We'll actually print out the photo and send it home with you so you can put it on your fridge, when you get home. And there's really no reason not to, have a consultation, just so you can get all the information. And for those, again, farther away, happy to do a virtual consult with you as well. So thanks so much for attending. Really appreciate it. Take care. Thanks, Dr. B. Bye-bye.